He's an ENT specialist. He graduated from UKM, MBBS, as well as his master. And he have done his fellowship in endoscopy, skull-based surgery, University of Pittsburgh. Without wasting our time, I think we go to the topic. Okay, the topic today is ears, eyes, brain, or something else. Pinpoint the cause of vertigo. It's a very important topic where we can avoid a lot of medical legal negligence. Our Dr. Puravi will make sure we will enlighten with all the good points, what to do and what not to be done. I'd like to call upon Dr. Puravi to do the presentation. Thank you so much.
Okay. Very good
before
evening.
Before that, 1 minute. Okay. This webinar is organized by MMA Slango. I'm Dr. Selvamutu, MMA Slango. Thank you so much.
Okay. A very good evening. I would like to thank MMA Slango and Dr. Selva for the invitation. It is a great honor to deliver this talk on pinpointing the cause of vertigo. Imagine standing perfectly still, yet the room is violently spinning around you, and you know it is vertigo, a symptom that sends millions of people to the doctors every year. When a patient says, "I'm dizzy, doctor," so a doctor becomes a detective, tracing the problem back to the fundamental question: which one of the body's balance system has failed? Is the problem the eyes? Is it a disconnect in the proprioception system? Or is it a processing error in the brain? Or most commonly, is it the culprit in the inner ear known as the vestibular system? So I'm going to talk on these three main pillars of our balance system: the vestibular system, visual, and proprioception system, and learn how their failure allow us to definitely pinpoint the cause of vertigo, classifying into peripheral or central. I have no disclosure. Now, dizziness is one of the most common complaint in elderly. It affects 30% of people aged above 60 and 1 in 2 above 85 years old. About 20 to 30% of elderly adults report at least one episode of vertigo or balance disturbance annually, and prevalence higher in women than men. Dizziness increase fall risk by 12 folds in elderly patients. Falls are the leading cause of injury-related death in adults above 65. And depression and anxiety are highly prevalent, about 30 to 45% in a dizzy patient. So let's look into the pathophysiology of dizziness, which is often complex and multifactorial. The symptoms can arise when there is a disruption in the sensory input. So it can be either a visual problem, or a vestibular, or a proprioception. All this information is sent to the central CNS system to be processed. And the motor output, that means information from the motor cortex. I think you remember during our undergraduate, the motor cortex sends the impulse through the corticospinal tract to the muscles. And however, if there is muscle weakness, if there is a muscle weakness or atrophy, the patient may experience imbalance or wearing while walking, even though they have a good visual system, good vestibular system, or a good proprioception system. It's like the bulb. So electrician will say if the bulb is not working, it can be either a bulb problem, a switch problem, or wiring problem. Same thing is that. If a patient have dizziness, is it a visual problem? Is it a vestibular problem or a proprioception problem? It's a job of the doctor to find out what is the cause. So the inner ear, so to answer that question, we must know the anatomy. So the inner ear consists of 6 end organs. As you all know, cochlea is for hearing and the vestibular system for balance. So the vestibular system consists of basically the peripheral system, which is the 3 semicircular canal, the utricle and saccule, and the vestibular nerve. Beyond that is the central pathway. So from the brainstem up to the cerebral cortex. So as you know, the visual cortex is in the occipital cortex, whereas for the balance cortex is in the parietal cortex. It's a special area called the parieto-insular vestibular cortex. So the peripheral system, basically the vestibular system, consists of three semicircular canal. These three semicircular canal and the otolith. The utricle and saccule is called the otolith. So the semicircular canal detects angular acceleration. What do you mean by angular acceleration? It's basically rotation. When you do this, it is detected by the semicircular canal, whereas the otolith, which is the utricle and saccule, detects a linear movement, that is gravity. It detects gravity. So, as I mentioned earlier, there are three pairs of semicircular canal. They all are orthogonal to each other. That means every semicircular canal 90 degrees with each other. So the lateral semicircular canal basically detects the yaw plane. So this is the yaw plane. When you do this, this is the yaw plane. The anterior semicircular canal detects the pitch plane. So this is the pitch plane. When you do this head movement this way, it's a pitch movement. And the posterior semicircular canal detects the roll plane. This is the roll plane. Now, next is the otolith. Now, when you see the otolith, what is the meaning of otolith? Otho means here, lith means stone. That means there's stone in the otolith. So, the utricle and saccule are known as the otolith. So, the utricle detects forward and backward movement or side to side. Whereas the saccule detects when you go up in the lift, up and down is detected by the saccule. So the sensitive part of the utricle and saccule are called the macula. So this is the macula, and you can see inside the macula you have hair cells, which is the longest hair cells is the kind, it's called the kinocilium. On top of it, embedded with the protein matrix. And on top of the protein matrix, we have the calcium carbonate, or also known as the otolith, or sometimes we also call it as otoconia. So you can see in this diagram, when he bends 45 degrees because of inertia, gravity, you'll see deflection of the kinocilium. When there is a deflection of the kinocilium, what will happen is action potential cause release of neurotransmitters, causing stimulation to the brain, saying that you have actually bent 45 degrees. So this is how the otolith functions. Next comes the visual stabilization system. So balance depends not only on visual acuity, but also on the proper control of eye movement, including the saccade system, smooth pursuit, vergence, fixation, vestibular ocular reflex, and optokinetic, all which are coordinated by the cerebellum. That means the cerebellum plays a very important role to fine tune all this eye movement. This eye movement ensures vision remain clear and stable during head and body movement, allowing the brain to accurately perceive spatial orientation. Now, look at the fovea. We are actually foveated animal. That means the most sensitive part of our vision is in the fovea. So you can see here, if the image falls on the fovea, the visual acuity is almost 100%. Okay, we can test it by a simple experiment now. I want everyone to stretch your hands out and look at your thumb. I want you to look at the right and left thumb. Okay, I want you to look at your now at your right thumb, the skin crease on the right thumb. Just focus on the skin crease on the right thumb. What is the image of the left thumb? You will see is blurred. So basically, what is happening is the right thumb is exactly falling on the fovea, whereas the left thumb is falling out few millimeter out of the fovea. You can see that within a 2.5% degree from the fovea, you have 50% visual acuity loss. So that's why we need clear vision to get good balance. So we'll start with the first eye movement, which is the saccade. So this is a saccadic eye movement. You can see the eye is moving from right to left. Saccadic eye movement is used to gaze around, or when you're doing a quick reading. If you're scanning very fast, you will use a saccade. It is a rapid belastic eye movement, and this eye movement is recorded in the graph here. You can see this is very accurate saccadic eye movement. So now, what happens if you have a saccadic inaccuracy? So you can see this is a inaccuracy saccadic and drawn in this graph here in the VNG. So the eye does not goes like that and comes down. So this is called saccadic inaccuracy or hypometric saccade, occurs in Parkinson's disease or multiple sclerosis or cerebral stroke. So the animation will be something like that. So when the patient sees this is what they will see. When they have a saccadic inaccuracy, what they see is a vision, something like this, is blurred. Okay. Next is the second type of eye movement is called the smooth pursuit. Smooth pursuit is to track moving object when the subject is stationary, like tracking a bird flying. Okay, so that the smooth pursuit keep the image always on the fovea to get a clear vision. Now, what happens if your smooth pursuit is affected? You can see here, this is a upward smooth pursuit. So you can see on the graph, this eye movement is plotted in the graph. You can see it is no more smooth, comes saccade down, and then it's not smooth anymore. But if it's smooth means it should go like a sinusoidal curve like that. So if you look at the animation, this is what the patient see, the word jumping. Okay. Now, this kind of pattern normally seen in the brainstem, cerebellar stroke, or a migraine that can have a saccadic. This is called a saccadic smooth pursuit. Patient will complain, doctor, I feel dizzy, imbalance, I'm not myself. But we translate it to vertigo and give the patient anti-vertigo medication. Next is the vestibular ocular reflex. So in low frequency, you will activate your saccadic eye movement and your smooth pursuit. So once you start running, you automatically this system will not is not sufficient. So you have to activate a new eye movement system called the vestibular ocular reflex. So vestibular ocular reflex basically stabilizes vision during head movement. That means the vestibular mechanism start to function at higher frequency. At a lower frequency, you have your saccade and smooth pursuit. So, for example, while running, you can see if somebody coming in front of you, you can see them clearly because of your VOR is working. At that time, you're suppressing your saccade and smooth pursuit. So, we can do an experiment now. You can take, if you have a phone, everyone can take out your phone and switch to a selfie mode on the video. Now, I want you to slowly turn around to the right and record. Okay. While you're turning around, I want you to look at the surrounding but record your eye. Okay. And what you see actually is your VOR. This is what the VOR works. You look at the eye. Okay. The eye is moving. There's a nystagmus. So when you move to your right, when the head moves to your right, the eye moves to the left. And then that is the slow phase. Then you have a saccadic refixation to the right. So to get a clear vision, this is how you activate your VOR. So this is a simple pathway of the VOR. When you move, when you turn to your right, what happens is that the fluid in the endolimb moves towards the left, stimulating the endolimb, the copula, that will send impulse to the abduction, the sixth nerve, and that abducent nuclei, which sends the impulse to the lateral rectus. So it contracts the eye towards the left, and through the interneuron, it supplies the right medial rectus so that you have a conjugate eye movement. So this is how a VOR works. Okay, so you can see here, just now, this is the VOR working. You can see the whole room looks clear. Now, actually, what I can do is, what happens if the VOR is not working? I can suppress the VOR, or in vestibular neuritis, we see our patients come to clinic, vestibular neuritis, what they have is actually the VOR is not working. So when they come to you, they will have you can see the image is not very clear. So they basically have blurring of vision, or sometimes this is also known as vertigo, or this is what they feel. Sometimes some patients experience as blurring of vision, some patient feels like they are spinning, vertigo. Now, the fourth eye movement is visual fixation. So visual fixation is when they look to the right, they get a right beating nystagmus. So the eye cannot hold in one position. The eye is like moving around. So on the left side, they get a left beating nystagmus. You can see here, the eye is beating towards the left. Okay, you can see the eye is beating. So if you do the stimulation, this is what they see. The eye, they see blurring of. So they see the stimulation sheets, they see blurring when when they have their visual fixation not working. So visual fiction doesn't work in patient with cerebellar disorder, midbrain, or Pons stroke in this area, and the patient may develop gaze evoked nystagmus. Next is the optokinetic nystagmus. If you are in a car and looking out of the window and you're seeing the light poles, all are equally spaced. It happens that your eyes follow a pole with a slow phase. You can see a slow phase and then a fast phase. Okay. So, when the target exits out of your field, and then your eyes snaps back to the new pole. That's called the fast saccadic phase. So that when you have an alternation of slow phase and a fast phase, this movement is called a nystagmus, and this is known as a optokinetic nystagmus. Optokinetic nystagmus. So basically, so the optokinetic nystagmus will work when you are on moving condition. So depends on different contexts. When you are running, your VOR works. When you are in the car, your optokinetic works. When you are standing and scanning around, your saccade works. When you're tracking something slow moving, then your smooth pursuit works. All these are actually controlled by your cerebellum. Next is vergence, is a type of eye movement where both eye move in the opposite direction, either to maintain a binocular vision. Either it can be convergent or a divergent. Now, with all these six eye movement, which is controlled by the central nervous system, particularly the cerebellum, so to allow us to see clearly in different situations. So, for example, when a tiger hunts, it first uses its saccade rapidly to scan around the surrounding. Once it spots a deer, it engages a smooth pursuit to track the moving object. During the chase, when you start chasing, automatically your VOR will be working and optokinetic will be working on the background so that it doesn't hit on any other trees. Okay. And finally, when he strikes the deer's neck, it will use the visual fixation. So you can see here, now the tiger is scanning around. So it is using its saccade, and then the smooth pursuit start to work. Okay. It's going to track the and then your VOR and your optokinetic, and finally your gaze holding to strike the deer. So all this eye movement is controlled by the cerebellum to get a clear vision. Next is proprioception. So I've spoken about the vestibular system, the visual system. Next is the proprioception, or the body's sixth sense. It's the body's ability to sense its own position, movement, and balance without looking. So proprioception relies on a special sensory receptors called the proprioceptors found in the muscle, tendon, Golgi bodies, joints, and skin. These receptors sends continuous feedback to the cerebellum, allowing the nervous system to coordinate smooth and accurate movement. The proprioception system has the same domain as visual system. It works with lower frequency. It contributes about 10% in the for the balance. So the visual input, the vestibular input, the proprioceptions are integrated in the central nervous system to maintain stable vision and posture, resulting in good balance. So there are more than 40 differential diagnoses. I can say BPPV, vestibular migraine, Meniere's disease, vestibular neuritis, labyrinthitis, utricular dysfunction, patient with utricular dysfunction, saccular dysfunction, both utricular and saccular disorder. So the list goes on. So since you have more than 40 differential diagnoses, let me simplify the etiology of dizziness into peripheral, vestibular cause, central, visual, proprioceptive, cardiovascular, psychological or psychogenic, and medication induced. So BPPV is the commonest cause of the peripheral disorder, followed by um, vestibular neuritis, presbyvestibulopathy. As you all know, presbyopia is basically age-related loss of accommodation of the eye, ability to change its focus from far to near. Same thing can happen in the semicircular canal and the otolith. So this is a presbyvestibulopathy is a age-related balance disorder in the semicircular canal and otolith. Other causes can be due to Meniere's disease, vestibular neuritis, perilimb fistula, superior semicircular canal dehiscence, and acoustic neuroma, which are rare. Now, I'm only going to talk on the two common peripheral cause, BPPV, benign paroxysmal positional vertigo. So what happens is basically the otoconia or the calcium carbonate, as I mentioned to you in from the utricle, enters into the semicircular canal, and this displays otoconia causes stimulation in the semicircular canal during head movement and causing erroneous vestibular sickness and produces brief episode of vertigo. So here is you can see here is the otoconia. The otoconia enters into it can enter into the posterior semicircular canal. It can enter into the lateral semicircular canal, or sometimes it can enter into the short arm of the posterior semicircular canal. Very rarely, it can enter because of gravity, it can enter into the anterior semicircular canal. Okay. So what happens is when it enters, when the patient, this is a positional dizziness. So you can see here, when the patient lies down, causing the crystals to move and deflection of the copula, causing the eye to have nystagmus, and this is what the patient present as vertigo. Okay, it is lasts less than a minute. Generally, it lasts less than a minute. So, what are the symptoms of BPPV? Brief episode of vertigo, spinning, triggered by head movement. Example, picking up an object from the floor or top shelf. Sometimes we also call, if you look up and pick up something from the top shelf, rolling over in bed, getting up from the bed, and this episodic vertigo typically lasts less than a minute. So the predisposing cause for BPPV Because of aging, this calcium carbonate gets dislodged out of the otolith and enters the semicircular canal. Sometimes can happen after a vestibular neuritis or labyrinthitis. And this condition, a BPPV that occurs after a vestibular neuritis, is called Lindsay-Hayman syndrome. Now, what is also the difference between a vestibular neuritis and a labyrinthitis? Both also present with vertigo. That in labyrinthitis, not only vertigo, you have hearing loss. The other predisposing factor for BPPV is Meniere's disease, head trauma, vestibular migraine. In vestibular migraine, because of trigeminal vasospasm, causing these crystals to get dislodged from the otolith, prolonged bed rest, and idiopathic. So, types of BPPV, 80% are in the posterior canal, 17% in the lateral canal, and 3% in the anterior canal. Bilateral involvement is very rare, being normally bilateral, normally post-trauma. How to diagnose BPPV? Basically, using a positional test, such as Dix Hall pipe test for the right posterior, sorry, you do a right Dix Hall pipe for right posterior and a left anterior canal, or you do a left Dix Hall pipe for the left posterior and right anterior canal. So during this maneuver, we are actually stressing the semicircular canal, same like a stress test. You ask the patient to do a stress test and see ECG changes. Here, we stress the patient and look at the eye movement. Okay, by looking at the eye movement, we know where is the particle. So we have to observe the eye movement, and this eye movement can be recorded by either by handphone, video recording, or VNG. I use VNG to record this eye movement, which I'll show you shortly. Or you can use Frenzel goggle or M-gas to magnify your eye to look at the eye movement. Now, so what happens is, this is how a right Dix Hall pipe test is done. So during the head movement, so do the head posture, you look at the eye movement. So if you have a upbeating nystagmus, this tells you that the patient has got a right posterior canal BPPV. Maybe we should have one session only on BPPV, Dr. Silva. Okay. Treatment for BPPV is not medication. Okay, treatment is not medication. Basically, there are more than 22 variants of BPPV. So, the take-home message is there are many variants of BPPV. So, the maneuver depends where is the otoconia. If it is in the posterior canal, as you all know, more commonly we do the Apley's maneuver. If it is in the lateral canal, we can do a barbecue roll or Zuma maneuver. Anterior canal, very rare. And I have an interesting case. I had a patient who had 12 days of positional vertigo after head trauma. Actually, a coconut fell on his head, and the patient was admitted in a private hospital, complaining of his main complaint was positional vertigo with nausea. Patient received IV Stametil in the ER and referred to the neurosurgeon. Patient had a CT and MRI. Everything was normal, and he was treated with IV Maxolon, IV Nexium, and discharged with Betaser, and asked the patient to do van der Rohe exercises. After the third day of discharge, patient still had symptoms of positional vertigo. So he came to see me. What I did was I did a Dix Hall pipe test. So this is what you look at, this head position. So this is the right Dix Hall pipe test. You can see there is a upbeating right torsional nystagmus. So from here we know that this patient has got a right posterior canal BPPV. So treatment is, take home message is, main complaint of this patient was positional vertigo. So you must suspect the patient has BPPV. Next is to check which canal. Treatment is maneuver, not medication. So this patient actually underwent a Applis maneuver. Okay. So what I do in my center is I do a modified appli. Yeah, the success is even better than a Applis maneuver. So this is how a modified Applis maneuver is done. Lay down the patient with the head extended off the bed, 30 degrees for 1 minute, and then ask the patient 1 minute to look down, look at the floor or the ground for the next minute. So what you're trying to do is we are moving the crystal. So this is the posterior canal. I'm not good because it, so so we are moving the crystals from here back into the utricle. So that is the aim of this. You know that the semicircular canal don't have otolith. Otoliths are only found in the utricle and saccule. So this otolith actually arises from the utricle. So the maneuver is to put back the otolith or the calcium carbonate back into the utricle. So the take-home message is BPPV is not a complete diagnosis. Like this postman, if you give this parcel to Subang Jaya, you don't know which department to send, to who to send. So again, you need to give the right diagnosis. That means, is it a right posterior canal BPPV? Then only you know what maneuver to do. There are many variations, so treatment depends on the location. Another take-home message is no medication. Now, what are the problems in BPPV? Patient with BPPV, they are high risk of fall, unnecessarily treating with medication. Like this patient of mine, he had MRI CT scan done. This patient's main complaint was after a head trauma, patient had positional vertigo. So from there, you have suspicion already. This is BPPV. So your next step is do a simple uh, test, which is either you check the posterior canal or anterior canal by doing Dick's wall pipe, or a lateral canal by doing a maculopagnini test. So if you give medication for BPP patient have poor compensation. So patient will take long time for the patient's symptoms to recover. If you don't do the maneuver, it might take weeks to months for the particles to settle on its own. And if you don't treat the BPPV, the patient will have triple PD, PPPD. What is PPPD? So PPD is basically persistent postural perceptual dizziness. So what happens is after an acute vestibular insult, say example like a BPPV or a vestibular neuritis, the patient and the brain basically shift reliance from the vestibular system into the visual and proprioception system. However, in triple PD, there is a maladaptive persistent. That means the patient overcompensate, totally dependent on the visual and the proprioception. So, and the brain fails to reset after the initial issue. So the patient become hypervigilance or heightened awareness in complex, busy environment. Example, when they go to the grocery store, patient will have internal perception of motion or imbalance. They feel like rocking sensation. Sometimes they have panic attack and anxiety. So how do you diagnose triple PD? Basically, the patient must have symptoms of dizziness must be more than 3 months. Postural, this dizziness worsen when they are upright position, like sitting or standing. When they are lying down, they are okay. Perceptual, they feel dizzy and they perceive them surrounding is off balance, and the dizziness they feel is not vertigo but swaying and rocking. So in triple PD, most common occurs in anxiety and depression patient. As I mentioned earlier, 30 to 45 patient of dizzy patient will have anxiety and depression. So the treatment for triple PD is vestibular rehab therapy, cognitive behavioral therapy, and sometimes you can use SSRI such as Lexapro or SNRI, venlafaxine, SNRI can be used in this patient to increase the serotonin level. Now, supermarket syndrome. In visual vertigo, the pupillary size can increase. So this is called, so the pupillary size can increase and reduce. This is called pupillary hippus. It is found in migraine patient. Many patients with migraine can present this. So the supermarket syndrome occurs in basically when they go and go to a complex or busy situation, they can get vertigo, such as supermarket. So vertigo, as a result of being overstimulated by complex visual environment, such as supermarket, train station, reflective floor, cinema. Sometimes when they scroll the phone, they can feel dizzy. Now, motorist vestibular disorientation syndrome. I had a patient complain to me he had veering when driving. So every time when he drives, he feels that his car is going to one side. He has seen five mechanic before seeing me. He cannot drive in highway because there is abnormal optic flow from the when the right and left when the car overtakes, there is abnormal optic flow. So this causes the overload of information into the brain. So the patient has motorist vestibular disorientation syndrome. Patient complain of more of imbalance rather than vertigo. Majority of patient with motorist vestibular disorientation syndrome respond to vestibular migraine treatment, such as magnesium glycinate, calcium channel blockers, flunarizine. Sometimes vestibular rehabilitation with virtual rehab with 3D goggles can be used in this kind of scenario. Next is oscillopsia. So a patient with a bilateral semicircular canal and utricular secular affected, you can cause oscillopsia. Okay, so causes of oscillopsia can be occur in bilateral vestibulopathy or in patient with cerebellar stroke. It can be either peripheral cause or central cause. So symptoms of bilateral vestibular hypofunction, if a patient complains to you, I have unsteady gait while walking or imbalance, worsen when walking on uneven floor or walk in the dark. So in the dark, basically your visual cues are no more there already. So you are totally dependent on your vestibular and your proprioception. So if your vestibular function is not good, the patient will have unsteady when they walk in the dark, and sometimes they have movement blurring, induced blurring, or oscillopsia, as mentioned earlier. Sensation of off balance with head movement, and no symptoms. They have no symptoms when they are lying down, and sometimes this patient can also come with frequent falls. So how to diagnose? Basically, you can do a like patient with hearing loss. You do a audiometry to find out their hearing function is affected. So the cochlea is very close to the vestibular system. So we can do a vestibular function test, okay, to find out whether the vestibular function is hypofunction or not. So this test is called, depends on different frequency. At high frequency, we call it as the head impulse, video head impulse test. At mid frequency, we call it as functional head impulse test. At low frequency, we can do a caloric test or rotational chair test. So I'll show you how uh, a video head impulse test done. So what we look at, eye movement over head movement. The eye movement, the velocity of eye velocity over head velocity. So this is checking the left lateral. So you get a value like this. Okay. If you see anything above 0.8, then it's normal. If it's below 0.8, then it's abnormal. Okay. So you can see here, if the gain, that means the head eye velocity over head velocity is called the gain. If somebody has got 0.6 to 0.8, this is called presbyvestibulopathy. So this patient can have blurring of vision or falls. If the gain is below 0.6, then the patient will have oscillopsia. They can present with fall. Okay, this is what oscillopsia has shown to you earlier. Or sometimes they have blurring of vision. They don't see clearly. So if you go and see an ophthalmologist, the visual acuity will be normal. Only in dynamic condition, they have blurring. In static, they are perfectly normal. So for vestibular hyperfunction, you need vestibular rehab, balance training, gaze stabilization exercise, lifestyle modification, avoid carpets because you want the proprioception to work fully. Use of night lights, especially when the patient goes to toilet at night, ask them to on the light because you want the visual cue to work. And using mobility aids, walking stick or walking aids. Next is the central cause. Okay, central cause. So basically, most common cause of central vestibular disorder is vascular in cause. Reduced blood flow to the posterior circulation. You know, posterior circulation, stroke or TIA, cerebellar infarct, vertebrovestibular insufficiency, especially in the pons and midbrain where the eye movement control centers are located. Other than that, in Parkinson's disease, cerebellar ataxia, multiple sclerosis, vestibular migraine. These are all our causes of central causes. So, as you know, for the brain, we have two circulation. What is the anterior circulation that goes through the carotid artery, internal carotid artery, and the posterior circulation. The posterior circulation starts from the subclavian, vertebral artery. So we have V1, V2, V3, and V4. And then the vertebral artery, both vertebral artery forms the basilar artery and supplies the posterior circulation. That means it supplies the cerebellum, which is important in the eye movement, supplies the medulla, supplies the pons and the midbrain, where your third, fourth, sixth cranial nerves important for your eye movement. Okay, so you can see this is the basilar artery, blood circulation, the ICA, which supplies the cerebellum. So if you have an infarct in this area, patient will have a lot of eye signs, which will the patient present with blurring of vision, dizziness, and so on. Now, I have an interesting case. A 60-year-old teacher had several falls on. She came to me with walking on walking stick. Her main complaint, dizziness for past 10 years, having drop attack and with fainting spells when she turns her head to the left. She was on Betacert, Stamatil, Stugeron, Marisolon, uh, antipsychotic drug, SSRI, and antidepressants. So this patient, when you turn, so that when the patient turn to the left, patient feel dizzy. Patient actually fainted. Okay, what this patient actually had is you can see here this patient had a hypoplastic um, right vertebral artery. So when the patient turned to the when the patient turned to the left, this part got kinked. Okay, when this kinked, there's not enough blood supply from the right vertebral artery. So the blood flow to the reticular activating system, which is in the midbrain, pons and medulla, was affected. So the patient loss of consciousness. So you see, this patient actually had a central pathology, was treated with, I think, of years of beta cell. So there's another patient, 65-year-old lady, presented with imbalance. She don't have vertigo, but had several falls. Now difficulty in walking, so she came on the wheelchair. She's seen neurologist ENT on beta-circ, stamatil, cinnarizine, tanakan, neutrophil for more than 6 months, no improvement. Her main complaint was actually words jumping when she walks. Words jumping when she walks. So you can see this is a upward smooth pursuit. You can see the smooth pursuit is so saccadic, and this is what she actually on the stimulation. This is what she complains. She has very choppy saccadic pursuit. MRI brain showed a stroke. So what we have to do is stop all the anti-vertigo medication. This patient actually needs a neurovestibular rehabilitation. And basically, you can ask them to do lower limb strengthening so that you reduce the risk of fall. These are all are central causes of vertigo. Now, sometimes patient can have downbeat nystagmus like this. Okay, downbeat nystagmus, patient will have causes can be due to cerebellar stroke, and patient will present to you with actually not vertigo, more of oscillopsia. This is basically managed by the neurologist by giving potassium channel blockers such as 4-aminopyridine or 3,4-diaminopyridine. And there's another condition also patient can present with oscillopsia or blurring of vision is called periodic alternative nystagmus, PAN, P-A-N. So what happens is for 90 seconds or 2 minutes, the eye will be beating towards the right side, the nystagmus, and then the nystagmus slow down, and then you will start to beat to the left side. This is basically a problem in the cerebellum, which is known as the nodulus or uvula. Okay, so the patient will present with oscillopsia or blurring of vision. Treatment for this is basically uh, baclofen. Next is sometimes patient will have gaze evoked nystagmus. So they have blurring of vision, oscillopsia. So treatment is using thick periphery glasses so that when they look at the periphery, they can't see. So they also to avoid the oscillopsia. This is one way of treatment for gaze evoked nystagmus. So basically, all this just mentioned to you, okay? And you know that cerebellum, during the undergraduate, you've learned that cerebellum have got three parts: spinocerebellum, cerebrocerebellum, and the vestibulocerebellum. So the vestibulocerebellum, also known as the flocculonodular lobe, very important for eye movement. The flocculonodular lobe is divided into three parts. One is called the dorsal vermis, the nodulus and uvula, and the flocculus and paraflocculus. So if you can't remember what the take-home message is, if there is a cerebellar problem, patient will have oscillopsia, they will have difficulty in reading or seeing, or they have when they change gaze. That's all the take-home message. Next is visual cause other than eye movement, visual cause. Okay, either it can lead to uh, blurred or distorted vision, poor depth perception, and difficulty in focusing, such as patient have got a refractive error, presbyopia, cataract, glaucoma, macular degeneration. This diabetic retinopathy or binocular vision disorder. This is purely managed by the ophthalmologist. This kind of patient basically they don't have vertigo. They more have imbalance, unsteady rather than vertigo. Somatosensory or proprioceptive disorder due to diabetic, alcohol or chemotherapy induced neuropathy, patient with cervical spondylosis, lower limb weakness, osteoarthritis affecting the gait, post-surgical or traumatic loss of proprioception, or age-related decline in proprioceptors. Cardiovascular causes. Orthostatic hypertension is one of the most commonest cause and can be due to antihypertensive, diuretics, prostate medications, nitrates, and alcohol. Cardiac arrhythmias also can cause dizziness. Psychological, I've mentioned to you already, triple PD. Medication induced basically can be either vestibulotoxic drug or ototoxic drug, CNS depression, cardiovascular drugs, psychotropic drugs. So the take-home message is proper history taking is the key. There are more than 40 differential diagnoses of vertigo and imbalance. 90% of the time, diagnosis is made through history. Common cause, benign paroxysmal positional vertigo. As you know, there is no medication needed. Treated with repositioning maneuver. Next common cause, vestibular migraine. In addition to medication, identifying and managing the trigger, such as sleep deprivation, irregular meals, and stress, pressed by vestibulopathy, age-related vestibular decline. No medication required. Emphasis on balance rehab and fall prevention. These are my reference. So, do you think is a dizzy patient here? Anyone can answer? The answer is the ball. So I just want to share my last slide here. I had a 67-year-old lady was admitted for positional vertigo and vomiting. So she was brought to the ER because of vertigo. A CT brain was performed in the emergency department to rule out intracranial bleed, followed by a neurology referral to exclude posterior circulation stroke. So the MRI brain was subsequently reported normal. The patient was treated with beta-circ, 24 milligram BD, and discharged home in stable condition. All seems to be well until the same evening, round 2 began. Patient had vertigo with palpitation. When the patient lied down, the patient had severe vertigo and patient had palpitation. The patient was brought back to the ER. This time, they referred to the cardiologist because patient complained palpitation. So Holter test was done, all were normal, then referred to the ENT and beta double dose was given, stamatives were added for good measure. Still at dizzy the next day, orthopedic referral was given to rule out psychogenic dizziness. Neck stiffness was noted, so the patient was rolled to the physiotherapist. 2 days later, patient still had dizziness. So, poor patient became like a ball being passed around every subspecialty, bouncing from neuro to cardio to ENT to ortho and to physio and to the psychiatrist. Thank you. Animals also can have nystagmus. Thank you.
Thank you so much. Thank you so much, Dr. Puravi. It's a very good enlightenment for our GPs. Okay, we have two questions. Does hands-free handphone affects vertigo? Is there any research on this?
No, hand-free does not cause vertigo.
Okay, the second question, who should see a case of vertigo? First, which specialty?
Basically,
Neurosurgeon?
no, basically anyone who's got depth in the knowledge of vertigo, that's all. It can be a neurologist, it can be a neurosurgeon, ENT, or GP. Okay, because this you look at that most commonest cause of uh, vertigo, peripheral vertigo is BPPV, and you know in BPPV the symptoms very classical. Patients say, when I lie down, I feel dizzy less than a minute. When I turn around in bed, I feel dizzy. Or when I look down and pick up something, or when I look up to take something from the shelf, I feel dizzy. From there, as I told you, that history is the most important in vestibular medicine. So, so when the patient has positional vertigo, the next step is that must trigger you already. This is it's BPPV. Next is I want to know which canal. So you have two maneuvers. One is a Dix-Hall pipe test. Another one is called a Maculopagnini or supine roll test. The supine roll test will tell you for the lateral canal. The Dix-Hall pipe will tell you for the vertical canal. So once you identify which canal, you can use your handphone during the when you do the Dix-Hall pipe. Use a handphone to record and slow motion. You can see the eye movement, play back and see if it is you have upbeating nystagmus during a Dix-Hall pipe. That tells you that patient has got BPPV. So the treatment is doing the maneuver. So it doesn't matter who manages it. So basically, as long you know what you are dealing with it, that's the most important.
Oh, that's a very good one. There is one more question. Is beta sex useful in vertigo? How long can patient takes it?
Okay. First of all, for vestibular medicine, when the patient have got acute vertigo, okay, there are basically in the blood-brain barrier in the brain, yeah, in the we have two centers, vomiting center and the CTZ center. So we have actually five uh, receptors there. One is called the H1 receptor, histamine receptor. Okay. Next is the dopamine receptor. I can't write with the mouse. Okay, D2, dopamine receptor. Then you have the muscarinic receptor. Then you have the 5-HT3 serotonin receptor and the GABA receptor. So, so you basically when we give stametil, where are we acting? Working. It's working on the D2 receptor. So you block this. When you give antihistamines such as um, meclizine, it acts here. When you give scopolamine, acts on the muscarinic. When you give clonazepam, acts on the GABA. When you give serotonin, 5-HTC serotonin blocker, it acts on that. So basically, in acute attack, if you look at beta-circ actually increases the histamine level. If you look clearly, it's a H3 antagonist. So it basically increases the H1 level. So beta histine can be never used in acute vertigo. Basically, when increases the histamine, increases blood flow to the inner ear. So it is only used in Meniere's disease. The next question is, how many Meniere's disease you see in a year? Okay, so to answer the question, beta-circ should be never used for acute vertigo. You need to block the H1, not to increase the H1. So it is actually a more of a placebo rather than acting on the receptors.
Okay, thank you so much. One last question. Can vertigo last for 2 to 3 minutes and ends with a tinnitus? Also, even during sleep, not positional related, but all day.
No, can you repeat the question?
Can vertigo last for 2 to 3 minutes and ends with tinnitus?
Okay, so vertigo and tinnitus can occur together. What are the conditions can cause this? Number one, vestibular migraine. So in vestibular migraine, patient will have vertigo. So vertigo and vestibular migraine, 30% occurs minutes, 30% occurs hours, 30% occurs days, and 10% occurs in seconds. In vestibular migraine, they can have tinnitus, neck stiffness, okay, and with dizziness lah. They can have rocking. Sometimes they don't have to have uh, spinning attack at all. They feel rocking sensation. Now, what other condition can cause vertigo for minutes or sometimes seconds is vestibular paroxysmia, where there is vessels crossing on the uh, vestibular nerve can cause. Other condition, vertigo with tinnitus is in Meniere's disease. Only thing is, Meniere's disease, the vertigo and tinnitus last more than 20 minutes, not 3 minutes or 2 minutes.
I think that's good. That's good enough. Thank you so much, Dr. Puravi. I'd like to
Most
thank,
welcome.
on behalf of MMA Selangor, thank you so much. We would like to see you again in future for other topics.
Thank you.
Good.
Thank you
Okay,
for
thank you. Good night.
most welcome.
Good night. Thank you so much.
Okay.
There is around 117 participants tonight. It's
Okay.
supposed to be very good.
Okay. Thank you. Thank
Okay,
you.
thank you. Bye.